Hello, everyone. My name is Dr. Richard Horowitz, and I'm the co-host of the Dr. Talk Healing Lyme Summit 2.0. It is my great pleasure today to introduce to you Dr. Robert Bransfield. Bob is one of the leading experts in neuropsychiatric Lyme and tick-borne disorders in the world. I've known Bob for a very long time, and we're going to discuss today the neuropsychiatric manifestations of Lyme and tick-borne disorders and some of the ways of treating them. So thank you, Bob, for joining us today.
Thank you, Rich, and I'm glad you're educating people. I think it's a great service.
Yeah, my pleasure. So, Bob, just tell people, how did you get into this? A lot of psychiatrists, they don't necessarily treat Lyme or tick-borne and are aware of it. Why did you get into this and other psychiatrists haven't?
Well, I was trained as a Freudian psychoanalyst. That was my training. And I did have question that you couldn't blame your mother for everything. That didn't really make sense. And kind of like that, you gave a story sometime about how it transitioned with that word, demon possession and all that. Okay. But then it's like there's something more to this. And how can you explain mental illness? It's a very complicated formula. It's not a simple formula. And I think pretty early on, I thought maybe infection could play some role, but it was hard to make sense out of it.
Mhm.
And I ended up seeing a lot of treatment-resistant cases. And I specialized in that, and cases that weren't responding, and you couldn't just give an antidepressant and it would automatically work in 2 weeks and it'd be fine. So you had to think harder and think outside the box and look at what was it that was causing it. And so in doing that, I found infection maybe played some role. At one point, there was a slow virus theory. And then we looked at toxoplasmosis as a thought, and I remember seeing cases like that. And then in the 80s, I was seeing a fair number of AIDS cases, HIV cases. And in psychiatry, we often see what nobody else wants to treat. So when people throw up their hands and say, this makes no sense, go see a psychiatrist, we get referred to people that are lost in our healthcare system.
Mhm.
And then once the healthcare system gets a better handle on something, we no longer see it. So in the 80s, we had more of these HIV cases. Then the world embraced HIV, and then we stopped seeing those cases. But the Lyme cases, I know I can think of Lyme cases going back to the early 70s, but
Mhm.
I didn't identify it as that then, but I could think of it as when I look back at that case that baffled me then, that there's something I'm missing here. I
Right.
know it was a Lyme case, I'm sure, but at the time we didn't have that concept. So I was seeing some of these in the 80s and then particularly in the early 90s, and I was seeing more and more. And I thought, well, who can I send these to? And I couldn't find anybody to send them to, so I had to figure it out myself. And then once I figured it out, I could see that the infection was playing some role, and some would be referred by infectious disease doctors, and they say, well, they've been treated with a month of antibiotics, so they should be cured. And should's a dangerous word in medicine. Should and never, okay? You should never say should and you should never say never, okay? But and I would get these cases and then I would say, well, maybe the infection wasn't adequately treated. And I would give the antibiotic and they would do better. And then it seemed to make sense that there was some process that was driving these people. And they often were a little bit different than some of the run-of-the-mill psych cases,
Mhm.
because they often had everything was wrong. They had physical symptoms, they had uh, cognitive symptoms, they had psych symptoms. And some of them, it seemed like they kept getting worse and worse and worse with the same treatment. You had to treat them more and more to do more and more psych meds. And so something was pushing their illness in the other direction.
Right.
And what was that? And the antibiotics seemed to push back and it helped some of these people. And so then I treated these cases because I had to figure it out. And then I found there were some other psychiatrists, Brian Fallon, and some other psychiatrists uh, who were Virginia Scher, who were seeing some of the same things. I organized a meeting at an APA meeting, that's American Psychiatric Association meeting in the 90s. And I said, let's get together and talk about this. And it's like, we're all seeing the same thing. And let's work together on it. So then we organized some, and I started a internet discussion group for psychiatrists. And then we shared information. We went back and forth. And then that's continued since then. And there's been pretty consistently around 750 members in that group ever since.
Mhm.
And some people have come and gone, and sometimes we have psychologists or other doctors or social workers or other people that are involved in treating the mental aspects of infectious disease. And we don't just look at Lyme, we look at any infection. So we call it microbes and mental illness, and look at the connection there, knowing that it's one theory is mental illness isn't a gene. There aren't that many mental illness genes. There may be half a dozen you can find, but there are many, many, probably thousands of mental illness susceptibility genes. And these susceptibility genes may be beneficial in one circumstance and contribute to illness in another circumstance.
Mhm.
So if it's the formula that we call it the disease triangle, so you have some susceptibility on an environmental trigger, and that causes a disease state.
Right.
So
So,
you can get
so question,
identical
Bob.
twins that are different. Okay.
Yes. So question, because in this day regarding the microbes and mental illness, it's obviously not just Lyme. We're seeing a lot of
Right.
Bartonella, which is causing severe neuropsychiatric problems. Long COVID has now come along. Long COVID is associated with a large number
Right.
of these mental illness cases. So are you finding that the standard drugs, you were saying earlier that one of the ways you recognize that someone may have neuropsychiatric tick-borne is they're not responding to the classical drugs. They've got physical symptoms, not just psychiatric symptoms, right? And resistant. But are you finding at this point things like long COVID, Bartonella are complicating the issues for you, like way more than they did with Lyme from years ago, that you've got to think even out of the box more, use other antibiotics or other ways of lowering down inflammation? Because you've published on the fact that all these mental illnesses, a lot of them, it's just inflammation in the brain, right? That's driving a lot of this mental illness.
Yeah, sort of. Although it's like this, these are complex interactive infections. I like that word. And that doesn't lock you in. If you look at what Lyme is a clinical syndrome that recognizes there was something seen in people in the Lyme, Connecticut area that had some common denominators. And when you look at that, and this is a project that Dr. Greenberg is working on now, she's looking at the initial cases that were studied by Polly Murray.
Mhm.
And an awful lot of them, the greater issue there was psych, not arthritic symptoms.
Mhm.
And she's finding suicide, homicide, a lot of psych issues with the people that she was looking at. But when people came in and investigated it, it was a rheumatologist. So there was a bias to look at the joint things and ignore the other parts of the illness. And unfortunately, then you had rheumatologists or infectious disease doctors who took control of Lyme disease, but they looked at it from what they understood, and they had very limited psychiatric capability. So then the psychiatric symptoms were put in a category that was called subjective and non-specific. And like, what does that mean? That means you don't know how to do a proper assessment of these very significant symptoms. Okay. So then there was an excessive focus on just the musculoskeletal symptoms, and the other symptoms weren't adequately addressed. And I think those symptoms, like the joint symptoms, are much easier to treat than the neuropsych symptoms. People that are partially treated often get relief from lesser treatment for the musculoskeletal symptoms, but not adequate treatment for the neuropsych symptoms. You need more treatment for the neuropsych symptoms. And also the neuropsych symptoms appear later. The average person I see is 9 years post-infection.
Wow.
And sometimes longer, sometimes less. So it's like calling syphilis a skin disorder. Yeah, it is in the beginning, but in the later stages, it's something else.
Right. So
And
what are the most common neuropsychiatric symptoms you see associated with Lyme and tick-borne disorders like Lyme and Bartonella? Why don't you kind of go through some of the most
well,
common?
the most common, you have the brain fog, you have the fatigue, and the fatigue is usually the symptom people complain about the most. But the actual psych depression is actually the most common. But
Mhm.
you have anxiety, you have mixed anxiety symptoms. You can have impulsivity, you have low frustration tolerance, you have an attention deficit kind of appearance. Although one thing unique about it is sensory flooding, sensory overload, where it's different than ADD. And sensory overload is I can't take too much stimulation. Like, don't take me to Times Square.
Mhm.
It's like I can't process it all. I get flooded and overwhelmed. I need a low stimulation environment. And so there, and slow processing and working memory, those are things, and time management problems, and innate intelligence can remain intact, but there's these other things that impair functional abilities that limit someone.
Right.
And sleep.
And you were saying earlier that even homicidality, you can see suicides and homicides from Lyme disease, right? You've published on this, in fact,
Yes.
a couple of years back in the medical literature. I think it's relevant this day and age because of the Luigi Mangione case that he has chronic Lyme, according to what we've read about. I don't think anybody yet at this point has gone into this in great enough detail, but it's certainly possible that some of his mental illness and lack of impulsivity and control could possibly be due to the tick-borne disorders making this worse?
Well, when I look at, let's say, tick-borne, when I do an assessment of symptoms, only 1% of Lyme, late-stage Lyme patients show homicidal tendencies.
Mhm.
And that doesn't mean they commit homicide, but they have homicidal thoughts or urges. Only 1%. So it's a small percent. So I don't want to bias the whole Lyme community, but still, if 1%, when you look at how many people have chronic Lyme, that's a massive number of people.
Right.
And now of that 1%, I studied that, and I've done maybe 5 or 6 different articles where I address homicidality with it. I did the autopsy where there was a homicide and a suicide, and then we looked at the brain, we showed the brain findings, and I've done statistical analysis. I've had legal cases of people that were homicidal or committed homicides. I studied that. 49 out of 50 homicidal Lyme patients that I studied were suicidal. So particularly you see this pattern where someone has this homicidal urge and they fight it, but and comes and it's like, where did this come from? But sometimes then when they act on it, particularly they take out a group of people and then themselves. So they may be homicidal and suicidal, and they may even kill the household pets as well. So a lot of these family homicide suicides follow that pattern. Some of the school patterns, shootings follow that pattern where they shoot and then shoot themselves, whereas that's different than what you see with other kind of crimes. And a lot of the crime that I see is like bizarre and senseless. It's like it makes no sense.
Mhm.
Why would someone do that? It's crazy. It seems illogical, but it's impulsive, and it's there's all different kind of patterns I've seen with it.
Right. And
So
do you find it's much worse? I mean, what I've seen is the neuropsych seems to be much worse in the people with Bartonella. Do you find that also there's an exaggeration of those type of
right,
psychiatric symptoms when they have Lyme and Bartonella?
right. I think when you look at it, if someone only has Lyme and nothing else, and Lyme is the most common tick-borne disease. So Lyme is a marker for tick-borne disease, but tick-borne disease is a complex infection of who knows what. And it can include Babesia bartonella. It could maybe toxo. It could also be relapsing fever. I think relapsing fever maybe that's the difference. That may be the people that maybe do get more the aggressive side.
Hmm.
And it's hard to say what is it, what makes that 1% different? What do they have that the other 99% don't have that makes them different? Is it a genetic susceptibility, or is it some infection that affects the brain in a different kind of way? But you
Hmm.
do see, I think Lyme is immunosuppressant. Lyme is immunosuppressant. HIV is immunosuppressant. COVID is. And then when you have an infection that's immunosuppressant, that activates other infections in your body that then become active, and it causes a complex interactive infection. So
Right.
the formula I have is when you have co-infections, 1 + 1 = 11, not 2. Okay.
Yes. And we
Because it
find, by the way,
interact.
we
Yeah.
we published last year that Bartonella also causes immunosuppression. We found in the people that had multiple Bartonella species, those were the ones that most frequently had chronic variable immune deficiency with subclass deficiencies, the worst neuropathy of the burning in the feet and all over their body. They had the worst
Yeah.
autonomic neuropathy and the worst neuropsychiatric symptoms.
So you could get Lyme that gets immunosuppression that activates Bartonella that makes the immunosuppression greater. Now you get opportunistic viruses or toxo or other things, or you get Epstein-Barr, um, and it's or other viruses that would otherwise just be latent. And a lot of times you see these viral titers go up when the Lyme is more active, and when you've successfully treated, then the viral titers drop, even when you're not treating those viruses, the HIV, the herpes type viruses. So
Right.
it's I think it's a very complicated formula, and we still don't know all of the microbes that can be in a tick bite. Okay.
Mhm.
And I think every year we find a new one. And what else is there that we're missing? All right. Like I remember back, I guess, what was it, sometime in the 90s, where we say, well, there's a new thing called co-infections. All right. And co-infections seem to be what's going on and why these people run difficult. We're still in that phase of trying to understand it, but we're still trying to understand all the implication of Borrelia and all the different subspecies of Borrelia. So this is a
Mhm.
very complicated thing that we're just gradually trying to understand better.
Yeah, and regarding the immunosuppression, what makes it worse when we do the MSIDS evaluation in our patients, we're finding mold toxins at this point. I mean, I'm probably saying at least 9 out of 10 people. Some new patients. I'm not taking that many new patients these days, just a handful. But one this morning who's about to come to me, she's loaded with mold toxins, and the doctor who's sending her over, just started testing mold toxins like gliotoxins are immunosuppressive. So as you said, if you have T cell exhaustion from long COVID and your B cells that make antibodies are affected by Lyme and Bart, and now you've got gliotoxins, your whole immune system is suppressed and these infections go wild. So, at least what I've read about is all of the neuropsych manifestations, and that includes even bipolar disorder, psychosis. You have seen tick-borne disorders drive some of these illnesses, correct? Where it's
Yes.
not just a question of giving lithium or giving antipsychotics, but when you actually treat the infections, they maybe don't need all of these psych drugs. You've seen this happen over time.
Right, but think of it, I think of three basic core areas to look at to get some of the complexity more manageable.
Hmm.
Think of disease drivers, and that can be infection, it can be mold, genetic vulnerability. Those are the disease drivers.
Okay.
Think of like an avalanche that starts it. Then you look at the immune system and what's going on in the immune system. And the third thing are the symptoms. Now, if you look at the immune system, ideally, you get early inflammation and then you get adaptive immunity and you're fine and it's done. With Lyme, you don't get adaptive immunity. You get persistent inflammation and autoimmunity, and it persists because you never get adaptive immunity. But the symptoms are associated more with immune activation causing symptoms than the direct effect of the infection itself.
Hmm.
Some symptoms may be from direct effect of the infection, but a lot are immune mediated. Then you get the symptoms. And the symptoms then, and think of the vicious cycle that keeps it going. If you're sleep deprived and you're chronically depressed and stressed and turn to substance use, and substance use is a big part of this too, then it's a vicious cycle that makes it worse. So how do you untangle all that so you turn it around in the other direction? You could treat the disease drivers, the infection or other things, but if that happened and it's been going on for a while, it's done a certain amount of irreparable damage that cannot be reversed. But some of it is active disease process, some is prior damage that's there. And then what can you do to make the immune system healthier? So it's helping you to adapt instead of having maladaptive immune system, even though that you can go in a lot of details of which immune transmitters and all that, and then looking at the symptoms. So I think working in those three areas, and in different people, it's different things.
Mhm.
What
So, so
what
do you some
started it and what perpetuates it? Okay.
right? Do you sometimes do the the genome mine? Do you said because you said basically the big drivers you were finding what kind of infections, toxins with genetic variants in a lot of these site cases, and in some cases you're also seeing in some cases these people can't methylate, so you give them an SSRI, it's not effective because they're not methylating up in the CNS. I mean, do you find some of these genetic tests like GenoMind are helpful in your particular case to like look at this at the same time?
Not that one, but this new one that's being done. It's a much more sophisticated testing. See, a lot of that really just shows are you rapid or slow metabolizer, sort of.
Right.
And people think that that means use this antidepressant, but not that one. It doesn't mean that at all. So I think those are not very useful at all. But I think this other testing that is uh, Hausman Cohen that she's doing, I think that's useful. And I think that's something that she's working on with this new testing, where what happens is when you get the illness, let's say somebody gets depressed, and now then we treat them. We give the antidepressant, it works on the receptor an hour after they take it, but they don't get better for a few weeks. Why
Hmm.
does it take so long? And what you're seeing is these transmitters, these genes are upregulating and downregulating. That's a key. So what she's Sharon Hasman Cohen, I think, what she's doing is looking at some of those pieces there and how people have different genetic susceptibilities that go into that, looking at the genetic sequence of how that process occurs.
Hmm.
And that can give insight into how to treat it, in a metabolic way. And I
Right.
think that's also being done in a diagnostic way with Patterson's work, where he's looking at the genetic markers, or the immune transmitter markers that
Right.
have to do with the pathological cascade. I think
Right.
that's the gene part that we have to look at, rather than these other things that really don't give that kind of information.
Yeah, we use Bruce's panel from Radiance Diagnostics quite a bit. I mean, I get them back a few times a week. And the chemokines and cytokines that show up there, we're seeing a lot of vascular inflammation with VGF and SDCL40. But the problem is, and I've spoken to him about it, the VGF as the vascular endothelial growth factor can be seen from the spike protein from COVID causing vascular inflammation, but it's an indirect marker of BART. And I said to Bruce, how do you know it's the spike protein versus BART versus both? And he said, well, we don't at this point. We've really got to look at it. I suspect when they look at these long COVID cases, because I did an MSIDS review and I just published it this year in April in Microorganisms 2024, we look at all 16 points on long COVID and found every one of the MSIDS factors I've used to diagnose and treat Lyme has now shown up in long COVID. It's also shown up in autism. It's also shown up in ADD, ADHD. It's showing up in Alzheimer's. We're finding
Right,
these, it's like rivers of inflammation causing an ocean of inflammation, and that the
right.
inflammation coming from infections and toxins and microbiome issues and sleep disorders, vitamin mineral deficiencies, and that it has downstream effects with like the mitochondrial dysfunction, neuropsych symptoms, autoimmunity, immune dysfunction, Pott's dysautonomia, liver dysfunction, pain
Right,
syndromes,
they're
right?
all part of the cascade of chronic illness. And like, for instance, if I did a study looking at different psych symptoms of
Yeah.
depression, bipolar, and interleukin 6 was elevated in all of them. Now, within each subcategory, there were different cytokines, but interleukin 6 was seen in all of them. So sometimes you get a common denominator with all these things, but then when you look at the details, sometimes you see a little bit of a difference from anxiety or depression or autism. So there are other transmitters that are different,
Mhm.
but it all makes sense. And a lot of the transmitters, like that upregulate and downregulate, the genes that upregulate and downregulate from health versus illness versus recovery, are immune system genes more so than neurotransmitter genes in the brain.
Right.
You
So,
have
so
two
Bob,
parallel networks in the brain, the immune system and the neurotransmitters, and they both
right.
occur at
So
the same time.
when you're dealing with this, when you're dealing essentially and it's inflammation in the brain, are you finding that things like low dose naltrexone, low dose melatonin to block neuroinflammation at the level of microglial activation? I know you've used Namenda in the past for NMDA. What do you like apart from using the standard SSRIs and bupropion? What are the alternative
But,
things you find are useful in these patients?
well, there's always something that works for somebody and doesn't work for somebody else, because I think a key thing is you can't lump all these people in one box. There's, I think a standard of care is all treatment has to be individualized.
Okay.
Everybody's different. And when you do formal studies, it's aggregate data. We don't treat aggregate data. No aggregate data has ever walked into my office. I treat individuals. So, and if I know what worked for their identical twin, that doesn't mean it works for them. Okay.
Right.
So, and then so you have to make that jump. And people that are in academia think of aggregate data. We treat patients. We treat individual patients that are very individualized, and you can't say that they fall in a box, a computer menu. They're all individual and they need to be seen that way. Now, I think what helps the most, and usually the number one complaint is the fatigue. And that's the most disabling that a lot of people have. And when I think of fatigue, the first thing I start with is get more restorative sleep. And lack of restorative sleep also makes someone more in a pro-inflammatory state. Although there's many other things, but when you're in an inflammatory state, it interferes with the quality of your sleep. So it's a vicious cycle. But I'll go through all my symptoms, and I just did it today with somebody. And then at the end, I'll say, when I go through my 270 symptoms, if I could help one symptom, what would help you the most? What's your worst symptom? And it can be different, even though fatigue or non-restorative sleep is a common thing. It's not the only thing. It's like, what is most troubling to them? And then we look at starting with that and working our way down the list. And if you're in a chronic stress state, that pushes, think of stress syndrome versus sickness syndrome. And people that don't do well with Lyme are people that are too hard driving, and they just can't stop and they can't back off. And if you could, when you're in stress syndrome, all your energy goes towards dealing with your environment. When you're in sickness syndrome, your energy goes more towards dealing with recovery. You need to get in that recovery mode and allow your body to heal.
Right. And sickness syndrome, for those listening, is what you get with the flu, what you get
Yes.
with Herxheimer's. These are like NF kappa B turns on, you get TNF alpha, IL-1, IL-2, IL-6, right? So it's these cytokines that cause inflammation that make you say, I want to stay in bed, right? I'm achy, I'm tired, I'm
Yeah.
foggy. Your body says, so that's the sickness syndrome, right? Just for people listening.
Right. The person there then who says, okay, I came down with a bug and I just curl up in a ball, sleep, take it easy. That person then recovers better. Whereas the person says, I'm not going to give in to this, right? I'm going to fight. I'm going to push. I'm not going to be weak and give in to it. And that person then never recovers because they can't let themselves regress and shift into sickness syndrome to recover and heal. Okay.
Right.
And you often see the people that, and it's often the movers and the shakers that get the Lyme because they're more active. And those people often have that quality of being push hard, drive hard, don't give in. And that's a trait that interferes with recovery.
Right. And you taught me
have to
years
allow
ago,
themselves to
Bob,
recover. Yeah.
and you taught me years ago with non-restorative sleep that people just don't respond to things like Ambulinestis sonata, that you've got to use specific drugs for like the phase 3, phase 4 REM, right, to get them
Right.
in.
Well, it's
What,
the delta sleep. Yeah.
yeah.
It,
So
it,
why don't you just mention a little bit for people listening, because I think this is important because it's part of it. why would you think about things like trazodone, or Seroquel, or low-dose Remeron? Like, why decide to use some of these instead of the classic sleep drugs for the non-restorative sleep?
Well, just about all the FDA-approved sleep aids are approved because they help onset be shorter and duration of sleep be longer. But they do not improve quality of sleep.
Mhm.
The only FDA-approved drugs that do improve quality of sleep are the narcolepsy drugs, okay, the sodium oxybate drugs that do improve. Now, sleep, you have usually about 4 sleep cycles. The first 2 are slow wave delta sleep cycles, and then you have REM. So it's the delta sleep cycle that really boots your immune system. And those are the first 2 cycles of the night. So you want meds that help promote delta sleep. And those are some of the meds that are approved for other things. Like we think of trazodone, uh, gabapentin, Seroquel. Those do have that ability to improve delta sleep. And that is often critical for recovery and healing. Now, REM sleep is then the next half of the night. That's more significant for psychological recovery. So that's where there's memory reorganization. Now, some people have more delta sleep deficiency, other people REM sleep deficiency, some people both. So you're looking at where's your problem and how do we want to impact sleep to make it more restorative, both physiologically and psychologically. So if, let's say, it's someone who has nightmares from post-traumatic stress, that affects more the REM sleep. So there we give things that reduce the intrusive symptoms, that reduce the nightmares. So then they're not tortured when they get the REM sleep, or they're not afraid of sleep because they know that they're going to have distressing dreams. When we block that, then they can rest better, and then they're more comfortable with sleeping.
Right.
So
So just
different
for
things are different.
example, yeah, so just for example, for the audience listening, just give them some examples of the drugs and dosages that you might use again for these, just so people
Right.
listening can.
Well, I think with all psych meds, here's what I think happens.
Yeah.
For whatever reason, a lot of Lyme patients are very drug sensitive. Now, it may be because you get a low body temperature, and a lot of Lyme patients have low body temperature. And when your body temperature is 97 rather than 98.6, you need lower doses of meds. But for but there may be other reasons too. So a lot of times with Lyme, you want to start often with a fraction of the lowest dose.
Mhm.
Now, every now and then someone has normal tolerance, but a lot of times people think that they're intolerant to something when really they took too big of a dose initially.
Mhm.
So it's often good to start with a fraction of the lowest dose. And if, let's say, it wasn't strong enough, then you go higher. But then you realize, are you really intolerant or you're just very dose sensitive? A lot of people have. Okay.
So,
So
so you're talking like Remeron 7.5, or even half,
or less.
or even less, instead of 15,
There
30,
were
45,
people
the
we
way
would
it's
take Remeron 7.5,
right.
put it in an 8-ounce bottle of water and have 1 ounce a night. So it's 1 milligram,
Yeah.
right? Or you could go low by making it compounded, just like with the disulfiram. There's some people that need 5 milligrams, or rather than, the 250 milligram tablet comes in.
Yes.
Or trazodone, we would start, that comes as a 50, that's the lowest dose. And trazodone is a good sleep aid. It's not addictive. It doesn't have the weight gain, and it does promote delta sleep. So that's a reasonable one to start with, and it's cheap. Okay. So a lot of times you'd start with 50, but you may, if it's someone's drug sensitive, you may take a fraction of it. It does
Mhm.
help onset in about 40 minutes, and then it helps quality of sleep. And then when someone first starts it, they may get a bit of a drug hangover for a few days because they're catching up on a sleep deficit, and then that works through. If, let's say, they consistently find I get a 3-hour hangover in the morning, then I'll say we'll take part of the dose 3 hours before bedtime, the other part at bedtime, and that way it wears off better and you have less hangover in the morning.
Right.
Or if it's 2 hours, you do it accordingly. Okay.
Right. Do you also like very low dose doxepin? I know it has a long half-life, but do you like, I
Yes.
find sometimes with mast cell, it has a very strong antihistaminic effect. And it also can be useful in some of these people, right? Just like I find pregabalin lyrica, I fortunately can use that with methylene blue. I can't use any of the other drugs except
Yeah.
for gabapentin, but you like those also.
I like both of them. Like the Doxepin, Doxepin comes as a 3 and a 6 as a sleep aid, but it's more pricey. It comes as a 10 as a capsule, but you can open it up. Doxepin, if it's there's a saying the young physician uses 10 drugs to treat one condition, and the older physician uses one drug to treat 10 conditions. Let's talk about Doxepin in that regard. It does help with deep sleep. It's also wonderful for GI distress, for people that have GI spasm, and a lot of Lyme patients have that. It improves
Mhm.
GI motility somehow. It helps nervous stomach. It helps irritable bowel. Okay. It also helps anxiety. It helps depression. It acts as an antacid, so it helps reflux. And so it you get a lot of benefit and it improves the sleep. So you get a lot of benefit, and often you don't need to go very high. Now, usually with like GI spasm, irritable bowel, nervous stomach, I'm usually looking at maybe 10, sometimes starting lower. And sometimes you say, well, start with the 10, open up the capsule and take a little bit at first, work your way up. 30 milligrams is often a common dose that works for GI spasm, where it's like the pacemaker. You have the pacemaker to your heart, but here we're talking about the pacemaker to your GI tract, right? And sometimes more, sometimes less. I've been as high as 400 milligrams for Doxepin in some people. And the normal antidepressant dose is 75 to 150, but we're looking at 10 to 20 to 30, sometimes 40 as the usual dose for the GI benefit, and the sleep benefit is 3 to 6. It can be quite low. So it's a very different dosing. It's a micro dosing compared to what we would give for depression.
Right. Right. So again, the kind of list for people listening, for those who have these problems with sleep disorders, which is pretty much every Lyme patient, we're looking at other drugs like trazodone, doxepin,
Mhm.
Lyrica, pregabalin, very low dose Remeron, even down to 3.75 or
Right,
less.
right,
That a lot of these can be useful. I even find sometimes Flexeril. I don't use a lot of it but I do use sometimes like 5 milligrams for those
right.
people that keep waking up in the middle of the night because it has a long half-life, right?
Well, Flexeril is very close to the Doxepin or amitriptyline, Elavil. It's a tricyclic, although it doesn't have the antidepressant properties. It has more muscle relaxant properties, and they're anticholinergic, which if you go too high a dose with those, then it can slow down the GI tract, maybe too much. But the low dose helps the motility because it reduces spasm.
Mhm.
Very high is reduces motility, but you're usually not going that high with the Doxepin or any of those.
Yeah. No, I've used your kind of dosing regimens over the years and found that if I use very low doses of this, I found that it's generally quite helpful. But you're right. I mean, it's a big problem talking about non-restorative sleep because when you don't sleep, you keep getting inflammation. The inflammation is driving all the underlying Lyme
Right.
symptoms. So
Yeah.
this discussion is particularly relevant
Yeah.
because even that will increase all your psych symptoms, right? Just not getting
Right.
the
And that's the example like the person I said before who's stoic, who
yeah.
push, ignore your internal body signals. Do what you have to do. Do what you need to do. Don't give in to your weakness inside. That's what you don't want to do.
Yeah.
And people with that personality makeup really do very poorly with Lyme disease.
Right. Bob, have you found that any of these newer techniques, a lot of people that we see do have trauma, either PTSD from going to, 10, 20, 30 doctors telling them it's in their head, or have had emotional, physical, sexual trauma early on. Do you find that some of these newer techniques that are out there, like some of the limbic retraining that's going on, or any of the, the vagal devices out there, are you using those in your practice? Are you finding them helpful at all?
Well, to some degree, here's what I think the role with trauma is, and you can think of adverse childhood events. I did an article on this, and in some ways, trauma is like autoimmune disease, where you get trauma, and ideally, you learn that this is danger, I stay away from it, and now I'm okay. So now you've adapted to environmental danger. Immune disease is where you get an internal sign of something, and your immune system learns to stay away from it. So if your immune system goes wrong, you get autoimmune disease and inflammation rather than adaptive immunity. If it's environmental, you get post-traumatic stress instead of learning what's safe and what's dangerous. Okay. Now, a lot of people are traumatized from having Lyme because of getting lost in the system. They don't understand it. The people that they interface with don't understand it. The healthcare system doesn't understand it. They're traumatized by it. And people say, it's all in your head. It's the aches and pains of daily living. Pull yourself up by your bootstraps and just push, and you're fine. And you had one dose of doxycycline when you got infected, so you should be fine. Or you had 1 month, and that should do it. That's what it says right here. See it in the book? See, I read this here. Somebody wrote this, so that should happen to you. And and they get traumatized by that. And the illness is traumatic, even if people around them understand it. But it also, there's a physiology to it. It gives intrusive symptoms, and intrusive symptoms fuels post-traumatic stress. Trauma and post-traumatic stress aren't always the same. So there's something about the physiology, how it affects the temporal lobe, that people get these intrusive symptoms that go with Lyme disease, and that fuels PTSD. That's the key thing. You get the intrusive symptoms, and that leads to avoidance, hyperarousal, and emotional numbing, which are the 3 major symptom clusters of PTSD. And so when you understand that, now I think that NMDR, can be, see, it's interesting. When you do a rhythmic activity, it seems like you somehow process it better. And that's the logic with NMDR. So what I think what you don't want to do is think about these things when you're lying in bed at night in a dark room doing nothing, because you're disempowered, but you're not doing anything that's empowering, but you're thinking disempowering thoughts. If you think those same things when you're walking on the beach during the day, you have more mastery over them, and you can process those thoughts. There's a difference between a bad memory and a traumatic memory. A bad memory is something upsetting that you've processed and you understand. A traumatic memory is something that haunts you that you haven't been able to process and understand. In some ways, it's like chipping an iceberg. You chip away what's on the surface and more keeps coming. And you don't want to do too much too fast. It's overwhelming and flooding. But you want to do it. And sometimes when it's too much, you want to just leave it there. Like people that are Holocaust survivors, don't go there. It isn't worth processing at all. Okay. It's too much. Okay. That's one option, to do that. And just don't go there. Don't open up Pandora's box. Or if it is within reason, you process a little bit at a time, and it makes sense. And the greatest trauma is trauma of trust, the betrayal of trust. If you're traumatized by a hurricane, you can better deal with that because I know it's not hurricane season. I know I'm safe. Okay. And when it is hurricane season, I'm going to get away from the shore. But if you're trauma of trust, you can't escape. It's like I trusted someone and they betrayed me. And all day long, I have to make trust decisions with people. And now I don't know who to trust, how far, in what way. I'm lost. And now I keep getting re-traumatized. And every time I have to make a trust decision, it triggers my old issues with trust. And now I'm lost.
So what do you do? These people are very, very resistant. I mean, I've seen them myself. Have you had to refer them sometimes for some of the newer psychedelic therapies,
Well,
apart from
no, I'd
ER?
avoid that. That can backfire. I
Yeah.
give them meds that reduce the intrusive symptoms.
Mhm.
And we think of like topiramate, Topamax,
Yep.
and prazosin. Those 2 meds seem to reduce intrusive symptoms, and sometimes periactin can. And so how they work that way, it's like, why does that one blood pressure med do it and others don't? But that's what studies have shown. And then when you have less of the intrusive symptoms, you have control over what you can access, and it doesn't flood you and overwhelm you. And then it's more manageable. Then you can look at it in a controlled way, make sense out of it, and understand it, and develop skill. And that way you're not lost with the numbness, the arousal. See, if you always have to be hyper, how are you ever going to recover? All right.
And we do see, so you like at the same doses of Topamax I might use for migraines, like 100 milligrams. Is that enough for
Yeah,
some of
well,
the?
let's start low. Now, the problem with that, the Topamax can cause brain fog. Lyme patients always have brain fog, but I
Mhm.
start it in the evening and I give it in the evening, and that's usually when it's more problem. And it also reduces carbohydrate cravings, so it helps with people that carbohydrate crave or weight gain. Okay, it also reduces alcohol craving. So it's you don't want to give somebody who's kidney stones or glaucoma, but then you start at night, and then often they develop a tolerance to it because the intrusiveness is worse at night. But then once they acclimate to it, then you can give it to them in a day and they may tolerate it better. Now, if the other one would lower blood pressure, and if someone has orthostatic hypotension, then that might be a problem. Okay.
Mhm.
So it depends on what's which one works better for them, which one they tolerate better. Okay. And then the periactin might cause weight gain. It's an antihistamine that you
Right.
may want to give if someone has formication crawling under the skin or itching, and that, or if they have mast cell activation, because
Right.
that's antihistamine, and that can, like, you're trying to help as more than one symptom with any med you give, because there's so many different symptoms. Where do you start? So you're trying to think which one works for the symptoms that you have, and which one do you tolerate best. And a lot of times you negotiate it, like what side effect are you more okay with or less okay with?
Okay. So basically what you're saying is, I mean, apart from individualized medicine being, of course, the hallmark of what
Yeah,
all of us do these days, you're saying in
yeah,
a lot of these patients, start low, start slow, and
yeah,
and
yeah.
and slowly go up because of the tolerance and the sensitivity that a lot of these
Right.
patients
Because a
have.
lot of times you give too high a dose, a person has a lousy side effect, and now they become afraid of it and don't want to touch it again, when really that could have been very helpful, but they started at too high a dose. And sometimes I revisit something that someone said they failed at, but they really failed because they had too high a dose. Now, occasionally I run into someone who needs a high dose of things, but I'll get there gradually.
Hmm.
They
Right.
may be a rapid metabolizer. I do have a couple of those people. See, it's on a bell curve. And if you look at psych meds, there can be 100-fold difference of people in one end of the bell curve or the other end. Now, when you get an FDA approval for a drug, you aim for the middle of the bell curve for aggregate data. But we
Mhm.
treat people at either end of the bell curve. Most of our Lyme patients are on that lower end of the bell curve with the psych meds. They might be on the higher end of the bell curve with antibiotics, but
Mhm.
lower end with the psych meds.
Right. By the way,
And
do you see, Bob? I don't know how much experience you've had specifically with Dapsone. I know disulfiram you've had some. Do you see? Because I've seen the neuropsychiatric symptoms get better after the infections are treated and the inflammation's lowered. Have you seen that you've been able to get some of these people off some of their psych drugs once you've
yes,
used these
yes, yeah,
persistent biofilm treatments?
yes, I've seen that. I've seen where, and even if I don't get them off it, they're on less. See,
Right.
when you have inadequately treated psychiatric illness, it ends up being a degenerative brain disorder. Okay, think it can begin with insomnia, anxiety, depression, dementia, and it can progress over decades. So if you treat it, you help reduce that progression over time. And then, but if there's some damage that occurred, so if someone, let's say, was infected with Lyme and went 10 years, and now you're treating this major psychiatric illness, it's hard to just give an antibiotic and they're back to square one,
Of course.
because they've had 10 years of disease progression that you can't reverse. You can reverse the current disease activity that is part of the symptoms that are present, but you can't undo the neurological dysfunction of the harm that's already been done to their neural circuitry.
Right.
So there's a limit to how, just like treating Alzheimer's after they've had it for 5 years, you're you may prevent it from getting worse in the future and help some of the current symptoms, but you're not going to turn the clock backwards to where they were before it began.
Right. And that's why I was asking about some of these newer techniques that are out there from the very resistant symptoms, because you read about Hopkins doing some of the studies of psychedelics. I've read it where all of a sudden
Well,
resistant depression and stuff gets better, or people that do certain drips to dissociate, right, with ketamine. But you're finding that even though I read about these, you're finding in your clinical practice it's not the answer for some of the big resistance.
here's the thing, particularly when in post-traumatic stress, you have to be careful. A number of years ago, they had these like encounter groups or so, where the way it would work is, hey, let's have a therapy weekend, and we're going to get together and we're going to have nonstop psychotherapy. Let it all hang out. Tell your deepest, darkest secret, and that people would end up with suicide. What would happen would be it was too much too fast, and that's not good. You want to do a little bit at a time. You want to open up that box and talk about it and close the box up on command. You don't want it to flood you. And then once it's out of the box and you're overwhelmed with all your old traumas that are hitting you at once, it's like the scene from Ghostbusters. If you remember the movie Ghostbusters, they have the box and they open it up and all the spooks come flying out. That's what you don't want, okay? You want to let out one spook at a time, and we make sense out of it. And now once we wrap that up in a nice package and we understand it, then we open up the box and close the box and do one spook at a time, okay? Not the whole army of them coming all at once. So I think anything you do, you don't want to be you don't want to be too aggressive with it. Better you do it too slow than too fast. And that way a person can acclimate to it, learn, adapt to it, and it's not flooding and overwhelming, and then they get stuck and they're traumatized by the therapeutic process. Now with the psychedelics, they can go either way. It's kind of like, yeah, there's parts of it that may help, but parts of it that may not. And it is experimental, and I think it's good to see it in an experimental realm. And there are some times when you get bad outcomes from it. I've seen that with ketamine, and
Mhm.
it can go either way.
Yes.
It's hard. The complexity it's humbling, the complexity that we deal with these things. So we have to be careful about the potential downside that is individualized. You
Yes.
know,
So, Bob, we're getting to almost an hour of speaking here. So, question: people are going to probably want to contact you to have questions. They may, of course, want consults. What is the best way for people to get in touch with you?
ask their doctor to get in touch with me, and their psychiatrist to get on my list, because listen, my office staff here is traumatized by all these phone calls, okay? And I'd like to be able to help everybody, but at this point, we really have to train more people, like you have to train more people. And we're trying to do it as best we can, because, I think these are basic things that doctors can do. I've been working on a training module, and I'm not sure what format it'll be, but it's over 500 slides right now about neuropsych Lyme disease,
Hmm.
and breaking it down. And it's not all 500 PowerPoint slides at once, but it's broken down into about a dozen different sections. And we're trying to think of a venue to do that with as a CME program.
Hmm.
And I think, what's good is if they could get their doctor or their psychiatrist, someone with an open mind and wants to learn more, and then they contact me and I put them on my list and they can learn it. And then when I get all these phone calls, then I'll have more people that I can send these patients to. But
Right.
there's just this affects too many people. It's not a small thing. This has a massive impact. And people are gradually becoming more aware, but we have to recruit the people that treat this and not feel that they can send everybody to you or me.
No, we all have the same problems that we're some of the pioneers on the front lines and have been doing this for a very long time. So in any case, the best way really to do it, and of course I have a training program on my website. I train docs. ILADS does it, but you're saying the best way is really to get their doctor to contact you, and then get some of the training that's needed.
Yeah.
Okay, good. Well,
Yes.
Bob,
Yes. I
thank
think
you.
that's the best way to do it.
Great.
Okay.
Anything else we didn't cover today that you think would be important to share people before we sign off, or you think we covered the big?
Well, my current project isn't exactly Lyme, but I'm looking at the impact of how infectious diseases can cause mental impairments of different sorts. It can cause autism, it can cause developmental disabilities, it can cause mental illness. That's what we're talking about most today. In some people, it causes violence. And I'm looking at that whole issue with infectious disease and how it causes violence in some people. And it seems like in some parts of the world, that's particularly significant. Now we're not talking about so much Lyme, but other infections.
Mm-hmm.
And we find that there's parts of the world, particularly you see more of this closer to the equator. Now, that's not where there's more Lyme disease. Lyme is more in temperate regions. So we're looking now, maybe other Borrelia, or it may be other parasites. But I think these hotspots of violence, where violence is endemic, and this is the art I submitted this article, and it's going through peer review process now. And my hypothesis was in 2017, if ever in the future we get a pandemic that causes mental impairments that manifests as violence, that could result in global instability. That was what I said in 2017, in a meeting in Paris. Now we had the pandemic and we have more global instability. That hypothesis was proven to be correct. And now I'm looking at that in more detail. How does that happen? And when you look at we have this, we need mental health technology to catch up to weapon technology. We need to look at these problems the way we look at airplane crashes, understand every piece and prevent it from happening. So I think that infection not only causes all these problems with mental illness and disability and chronic illness and addiction problems, but it also contributes to violence. And we're looking at other infections. We need to understand that. We need to see the dynamics, and we need to be able to figure out how to prevent it. And I think that's it takes us, and we need to go there with that. And it goes beyond Lyme disease, Borrelia burgdorferi, and we have to look at this greater picture, because this, as well as COVID, gives us insight that infections screw up how our brain works. And all these problems we have isn't part of our innate makeup. It's a part of some kind of disease process that harms our makeup. And if we didn't have that disease process, we'd have a lot happier, more productive, more peaceful world to live in.
Yes. And again, the point you're making, which is extremely important, of course, is microbes do cause mental illness. And a lot of this is from inflammation. And the inflammation can come from bacteria, viruses, parasites, fungi. It can come from multiple sources. And we need to get to the underlying root causes of why people are sick and why they have mental illness, and just not just throw drugs at them. And that's ultimately what this personalized precision medicine model.
Yeah, and it's more than mental illness. It causes chronic illness. It causes behavior problems. It causes developmental problems. It causes addiction. It causes other things. And although throwing drugs helps in a downstream effect, better we treat it than never treat it. But it's good to work our way backwards and look at how it began in the first place. It's like a row of dominoes, and we're treating one of the last dominoes. It would be better if we could treat the first domino, but we want to treat every domino we can and understand how that disease process occurs. And we have to connect the dots and go backwards. And I think if we can, we can really get a lot accomplished.
Yes. Well, Bob, I want to thank you today for taking your time. It's a great talk. And again, for those of you who've been listening, my name is Dr. Richard Horowitz. I'm the co-host of the Dr. Hawk Healing from Lyme Summit 2.0. I've been with Dr. Robert Bransfield, one of the world's experts in neuropsychiatric Lyme and tick-borne. Bob, thank you again for joining us today. And for those of you who've been listening, we hope to see you again for another episode soon. Thank you.
Thank you, Rich. And I'm happy you're doing this again. Okay, thanks. Bye.
Thank you, Bob. Good seeing you.